Maddie, if you just go to the next slide. Just to summarize what we will be focusing on today. So we will be first kind of thinking together about what we might expect in terms of behavior problems when somebody presents to our clinic. We will then be talking a little bit about intellectual disability. The case presentation we were originally planning to do, but decided not to do because we will be using examples kind of from our work, and we didn't think we would have enough time to cover all of this. We will be then discussing the assessment process, how we assess behavior problems, the interventions that we are offering or that can be offered by services, and then factors which are affecting behavior. Okay. If you go to the next screen. Okay, thank you, Maddie. So first of all, what do we think by definition of the behavior phenotypes in PWS? Well, we know these are kind of set behaviors that we see associated with a particular syndrome, and kind of related to Prader-Willi syndrome, we've got specific behaviors which are also very helpfully mentioned on your website with some guidance, kind of what one might try to do about them. They include things such as temper outbursts, food seeking and stealing behaviors, resistance to change, argumentativeness, perseveration, could be on the subject, different topics, or in questioning, attention seeking or manipulative behaviors, skin picking. I think what's really important to recognize at this point that although this is a behavior phenotype, not everybody would actually present with all of these behaviors. And also the severity of the behaviors that they present with will vary from person to person. So we can see mild presentation to quite severe presentation. And it can be dependent on many other factors. Now, type of behavior problems that we see vary with age, with external environment and emotional development. We have actually spoken today, and I think the breakout groups earlier today were very useful to actually start thinking about different times, such as transitions, you know, kind of different issues, what kind of things might be impacting on the behaviors. But it could be all kinds of things. It could be the family home. It could be the community that impacts, could be educational settings. So all of these to be considered. Now, we're also kind of talking here about learning disabilities. So what we know from the research is that majority of people affected by Prader-Willi syndrome have mild to moderate intellectual disability or learning disability. However, we do see some young people in our clinic who have actually severe intellectual disability, and we see some with borderline functioning or average IQ, so no learning disability. And as a service, despite the name of our team, where the Prader-Willi service is based, which is mental health in intellectual disability service, we do see young people with Prader-Willi regardless of the level of intellectual disability that they have. So the only referral criteria to the service is that they have to have a recognized diagnosis of Prader-Willi syndrome and that they need to be under 18 years old. So these are the only two referral criteria. Now, one thing that we want to emphasize that despite talking about behavior problems, and obviously this is the topic and theme of our talk today, we also want to recognize how incredibly friendly, sociable, kind and caring young people with Prader-Willi can be, with excellent sense of humor. And actually, you know, majority of the time when we do meet them, this is what we see. It's the families probably that get the kind of to see the part, which is the reason for referral to our service. And I just wanted to reassure everybody, and I think I recognize some names here, so people who have actually accessed our service, parents who have been there with their children. We never underestimate stories that we hear. We don't believe that just because a young person who presents with us is incredibly charming and well behaved with good manners, that they actually cannot present quite a significant challenge at other times. So the next slide. Okay, so just wanted to clarify, so what do we mean by the learning disability? So the learning disability is defined as IQ lower than 70. So the term that we use currently is intellectual disability, in line with kind of general thinking at the moment. And the IQ lower than 70 is the cutoff according to ICD-10. So this is a diagnostic manual that we use. But also, as well as kind of possibility of having a learning disability, there are also specific learning difficulties that may be picked up. And they include, you know, processing speed, short-term memory, despite perhaps long-term memory being absolutely amazing and fantastic, which is something I often hear about young people. Difficulties understanding abstract concepts such as time, numbers, and money. But then also difficulties with generalization of learned behaviors, which basically means for us as clinicians who try and change behaviors, or for the families, that if young person has learned one behavior in one environment, it doesn't mean that they will automatically start using this behavior in another environment. They may need again to go through process of learning to use this specific behavior in a different environment. And this is to keep something in mind. And there is also a range of speech and language disorders. So as part of the assessment process, when somebody comes to our team, we normally do the full psychiatric assessment, which would include the cognitive assessment of a young person. And this is really in order to recognize these specific difficulties. We then use it as a part of our psychoeducation program that we offer to the families, which would be the first step of intervention that we offer following an assessment, where we would actually look at the particular strengths and difficulties of a young person, kind of management styles and management strategies, what's working in what environment, what doesn't work. But this kind of specific information is really important for us because it will inform us as clinicians, you know, what type of approach might be possible for young persons. So for example, would it be talking therapy? Would it be something that uses images? Would it be something that needs to be very adapted to the level of learning disability? So so-called adapted CBT, or adapted cognitive behavior therapy. So the next slide. Okay, so what are the kind of main things that we can offer following an assessment in our service? So first of all, we would offer parent training. And when I say parent training, that can have many different levels to it. So I already mentioned psychoeducation. So this is Prader-Willi psychoeducation that we offer to the parents, as well as the schools and all other professionals involved in young person's care. The reason for this is that we have recognized, but as well the literature recognizes and previous research, that there isn't kind of really kind of good knowledge about Prader-Willi syndrome. And it is a rare genetic disorder. I think I mentioned earlier today in one of the breakout groups, it is not uncommon to actually come to a special needs school to find out that they've never had anyone before with Prader-Willi syndrome, that they have not come across them. Psychoeducation is a way for us to ensure that everybody's got really good understanding in which ways Prader-Willi can affect young people, and what are the supportive measures that could be put in place for their educational placement to be successful, as well as for other services who may be involved to ensure that the right and appropriate support is offered. So I'm thinking here, for example, social services who might need to offer respite for the young person. And it's then again kind of thinking about risk assessment in terms of kind of food security and food management in a place like that. As well as psychoeducation to the parents on Prader-Willi, we may offer psychoeducation on autism spectrum disorder if this is one of the a diagnosis that the son or daughter has. And so roughly approximately half of the young people that we've seen in our clinic had additional diagnosis of autism. But sometimes this has been given and the psychoeducation has not been accessed following this, so we may offer this. We may also offer all of those psychoeducations about Prader-Willi syndrome and about autism to young people themselves. So it's not just the parents. We would usually do those separately because we would kind of aim them kind of at different levels. So obviously for a young person, it would be kind of delivered at a point where they can access it depending on their learning ability level. We then have school-based interventions. So parent training, also kind of still talking about parent training. So what we also do is develop positive behavior support plan with parents. So we may be talking about parental management strategies that are used within the home to manage the young person. And I just want to reassure everybody, it's not that we've got magic wand. We're not thinking of any new interventions you haven't heard of. It's really looking at the interventions you are doing at the moment and thinking how we might adapt those to help work for you. So it's not about, you know, that there is something you've never heard of, but just kind of looking what's happening and how we might make it work better and be more successful for you. We also offer school-based interventions. And again, this may include psychoeducation to the school, but it could also include advice to the teachers about how to manage young person in relation to the class, how to integrate them better, or how to manage them differently, and that it still works for the class. So I think it's really important, for example, at the time of specifically transition to secondary school. This is the highest number of referrals that we get to our service is around ages of 11, 16 and 17. So these are the transition times. And this is where kind of all the difference and the difficulties start to rise, because there's all this emphasis on doing additional work, on having to be more independent rather than teacher-led in the classroom sessions, and it can have a huge impact on the emotional well-being and coping of young person in the classroom. Now, the positive behavior support plan that we may develop, it can include strategies for school, strategies for home, but it will be based on rewarding positive and ignoring negative behaviors. The part of it will be the sensory integration, so obviously recognizing where there are additional sensory problems may be impacting young person's behavior. We would be looking at structured activities, because we all know that keeping a young person busy and interested with activities that they enjoy and actually having joy in their life will minimize the behavior problems that there are. And we will be looking at proactive strategies rather than reactive. So we will be looking what to put in before the behavior happens rather than what happens after. So Maddie will be talking later on about kind of ABC charts, which we use for assessment of behaviors. So some of you may be familiar with these, but they have 3 columns: antecedent, behavior, and consequence. And so in order to impact the behavior in the middle, you change either what happens before, which is antecedent, or consequence, which happens after. And we want to change these antecedents because we know that by being proactive, you can actually avoid a lot of problems. And the next part is we want to address the function of the behavior. So we need to understand what the behavior is for the young person, what function does it serve. So I'll hand over to Maddie, who will talk a little bit about the assessment of behavior and how we do it.
Thanks, Natasha. So thinking about the assessment, the main aim of an assessment is to really understand why the child is behaving in the way they are. So what is the function or need behind the challenging behaviour that you might be seeing? Sometimes it's not particularly obvious, so that's why we need to complete a thorough assessment. So to do that, we'd want to get a detailed account from the parent. So what exactly are they seeing? How is it presenting? And how long has it been going on for? So thinking about the history of the behaviour, when did it start happening? Has it changed recently? So really digging around to find out more about the behaviour at home. Then we'd also want to get a similar account from other people, so perhaps teachers at school, to understand whether they see the same behaviour, and again, how they present, because often behaviours might present quite differently at school in comparison to home. So finding out how the behaviour is presenting at different environments. Direct observations are really useful, so we'd want to see the child perhaps at home and at school or other settings to see what's going on around them. And when we're doing observations, we want to think about what is the type of environment? Is it a quiet environment, a noisy environment, crowded, who's around, how are interactions between the child and other people around them, because it can be really helpful to see interactions with others. And then as part of that, as Natasha mentioned, we might also want to think about more specialist assessments, so thinking about the child's social communication needs and their intellectual abilities as part of the direct observations. So ABC charts, as Natasha mentioned, are really helpful in identifying patterns in behaviours and to consider functions and reinforcers or maintenance. So these should be completed. So I know lots of you have probably seen an ABC chart, but just to explain a bit more about them. So A stands for antecedents. So what is happening directly before the behaviour occurred? Who was around the child? What are the people doing? B is for behaviour. So what exactly was the behaviour? So for example, the child stamped their feet or they threw a toy. So it's really helpful to think about concrete information when you're recording the behaviour rather than abstract concepts such as the child was angry. So what was the child doing? Not necessarily their emotion. And then C is for consequences. So what did people do around the child following the behaviour? What did the child do? Was there a change to who was around? Were they changed? Was the environment changed? So this isn't really just thinking about the management strategy, but just exactly what was happening after the behaviour. And it's really helpful to complete these as soon as a behaviour is seen, without making interpretations. And a functional, so an ABC chart can be really helpful in helping us with a functional analysis of behaviours, which can be used to determine the factors that cause or maintain behaviours. So a functional assessment, it's helpful to have a clear description of the behaviour and identification of events over time, situation, and where the behaviours occur and do not occur. So are there particular times of the day or environments that cause behaviours? Are behaviours seen more in the morning, around the afternoon, or at night time? So really kind of getting a bit more of an understanding. Functional assessments help to identify any consequences as mentioned, such as negative reinforcement. So perhaps paying attention to behaviours by telling a child no, or giving into behaviours can also be a negative reinforcement that's sometimes seen. Then as part of that, so once we've got all of the information about the behaviour, we can make summary statements to explain exactly what's happening, what is the situation and what maintains it. And then ABC charts accompany this. We also often send out scatter plots and use scatter plots to help us identify behaviours. So they go alongside ABC charts and they give qualitative data. So often they look a bit like you'd have the days of the week across the top and then times of the day along the side, or routines or events or activities down the side. And then you simply tick or cross where you see that behaviour. So it can be really helpful to get a bit more of an understanding of what's going on. So gathering all of the information, as mentioned, really the main thing is gathering it from the informants. So interviews with parents and teachers. We also often have lots of questionnaires, and I'm sure many of you would have seen lots of different questionnaires that you've had to complete with services and professionals. Direct observations. As mentioned, these need to be carried out at different settings and at different time points. So we might do them at different days of the week or different times of the day. And then once we know more about the challenging behaviours, we can start thinking a bit more about the maintenance factors and the reinforcement factors. So, for example, we might find that a child becomes more aggressive in a noisy environment, and the consequence is that they then get one-to-one attention because somebody might tell them off or they might say no. So, as an example, the antecedent there would be being noisy, lots of people around. Behaviour is shouting and throwing objects, and then the consequence would be being told off or being told no, which is maintaining that behaviour. So then we might want to think about a functional analysis. So that's when we start making small changes. So we might manipulate the antecedent or consequence to evaluate the effects of different conditions on the behaviour. So we might try and think about other ways of reacting to the behaviour when the child is shouting and throwing objects to avoid, so kind of reduce that maintenance. And these condition changes are monitored closely to establish whether this makes difference to the behaviour. So there are many factors that might affect behaviours in children with Prader-Willi syndrome. So meal times is a big one, and keeping to a routine with meal times. So a child with Prader-Willi is likely to need to know when they're going to have their meal times and their snacks. So then it's important to consider this when having days out or when situations are changing. How can you manage the meal times? Tiredness or lack of sleep. So if a child hasn't had much sleep or they're feeling tired, then they're more likely to feel aroused, which could lead to some challenging behaviours. Changes to routine or unexpected changes. So changes without warning, not giving enough warning, can all be quite difficult, and that kind of goes into transitions there at the bottom. So this can be big transitions like changing class at school, starting a new activity, but also other transitions like becoming an adult or becoming an adolescent from childhood, and other smaller transitions like stopping a favourite activity without warning to move on to the next. Other things involve requests being made of the child, particularly if they do not understand what is being asked of them, and the child feeling like they are not in control, or if they feel they are unable to get their own way. So I'll hand back to Natasha, who will give us a bit more on that.
Brilliant, lovely, thank you, Maddie. Okay, so we were thinking here about kind of how to assess the behavior, but other things that we need to consider when we are managing behavior is, first of all, parental and carer approach. So again, we established this by interviewing the parents and carers, by doing direct observations of the interaction. And there are many things here that we are considering. And so first of all, we are kind of observing whether the parent is observant of little triggers and changes in the environment that may trigger the behavior. What is the style of intervening? So how they interact with the young person, because, for example, we know that a tone of voice can make a huge difference how somebody reacts to the information that they've given or restriction put into place. But we're also looking beyond that, and we're looking into kind of parents their own kind of experience of being parented. So, for example, if they were brought up by strict parents, do they think they need to be so-called strict parents, and when they say something, it needs to be followed? And we know that kind of when you work with young people with Prader-Willi syndrome, there are battles you need to pick. So you need to carefully choose where you're going to put something, stop something from happening, when you're going to just kind of ignore it and try to manage a different way, maybe plan ahead to try and avoid this from happening. But these are the kind of things that we consider this. We also consider cultural and social influences and stigma. And the reason why I'm mentioning this is that obviously we work in London Clinic, we meet people from all kinds of backgrounds and cultures with their own beliefs and traditions. And obviously we do recognize that there are some groups where any kind of illness any kind of disability is not looked at favorably. So we have situations, for example, where there's a young person with Prader-Willi syndrome where a parent doesn't want to say to anyone that the child has this syndrome and explain how it affects them. But there is a pressure, social pressure for them to attend all the social occasion, all the family parties, birthdays. And of course, you can imagine how difficult it then becomes for a parent to manage a situation like that for their child, and for them it's a proper nightmare. So actually, you know, any social events become really, really difficult. So we kind of try to understand things like that and try and work something that's workable for the families, that's acceptable to them, perhaps do some psychoeducation around that, offer to see other members of the family, extended family, in order kind of to help share the understanding. And then we also have other genetic factors that may influence the behavior of the young person. And these, what we mean by these, are additional genetic conditions. We heard earlier today some of the participants were mentioning different kind of syndromes that their children have, and how do they interact with Prader syndrome, what is more prevalent. You know, I certainly know that have parents who have got a child with Prader-Willi who has also autism diagnosis, that they say, oh, eating is not really an issue. Food-seeking behavior, actually, my child is much more like an autistic child in terms of management of their food. So the kind of pressure is on the food textures or colors of the food, or, you know, food's not touching each other. It's not about overeating for them. And then we also have mental health problems that can be associated with Prader-Willi syndrome, and that can affect them. So we know actually from the research that has happened so far, that a great majority, I think of around 80% of people with Prader-Willi syndrome are affected by some kind of behavior problem, and it could vary from mild to actually quite severe. In terms of mental health problems that we see mostly, it's anxiety in our clinic. When we actually looked at what's most prevalent, it's anxiety. But in addition, it could be ADHD, ASD, and psychosis, which we know is more, according to research, associated with maternal uniparental disomy type of inheritance. Okay, so next slide, please. Okay, so just going now through some specific kind of behavior, problem behaviors that we may encounter. So there's heightened interest in food. Generally, it emerges by 6 years, but it could be earlier. For some young people, it could be later. And it can be seen through excessive food seeking, eating and stealing behaviors. And it's actually quite interesting to follow how this may develop for somebody who may have not been interested additionally in kind of food, but certainly there's a focus on playing with food, playing kitchen, playing shopping, all to do with food. And then suddenly it becomes food that's served on the plate that becomes more interesting. There are also temper outbursts. I think kind of maybe a few years back, Professor Holland was doing one of his talks, and he did mention that in the past, management of food and food-seeking behaviors, or generally diet, was the biggest problem in Prader-Willi syndrome. But due to increased understanding of how it impacts young people with Prader-Willi syndrome, it's actually now temper tantrums and oppositional behaviors that are actually more challenging for parents to cope with. I think everybody's got slightly different experience, what's difficult for them. It is certainly number one on our list of behaviors when young people are referred to our clinic. So we analyze the data that we had from our referrals. So far, for example, we had approximately 40 referrals that we've received. more than half of those had, you know, kind of temper tantrums mentioned, challenging behaviors. Skin picking was also really high on that list. Now, we also have this rigidity, resistant to change, insistence on routine, and then arguing in things don't go their way. And this could be linked to this so-called autism spectrum condition type of behaviors seen in Prader-Willi. So, but not everybody has got that. And it's really important to say where somebody might have some parts of so-called parts of autism that we see, they may be extremely social and actually really enjoy the social interaction, not have the other bits, so they wouldn't qualify for diagnosis, for example, of autism. But then when somebody has got additional diagnosis of autism on top of Prader-Willi syndrome, this is where we see this rigidity and resistant to change, and being really, really difficult to shift either from their task or into environment, different environment, any transitions. This is where we see a real problem. Then we have perseveration, and this is repetitive questioning usually. Now, this is very, very common. I think most of the parents that I worked with would mention this. It would come up at different times, and it seems this behavior seems to be related to anxiety levels. And again, anxiety is something that we see in a majority of the young people on our team. And actually, in effect, we will be talking later on about medication. I'm really sorry Dr. Bennett is not here to actually talk a little bit more about this, but the main kind of medication that we would prescribe when we do prescribe medication, which is not for everyone, it would be for anxiety type of behaviors. So it would be anti-anxiety medication, or antidepressants are called. We then have compulsive behaviors, collecting things. Again, not everybody presents with, but then we have some who go to very extremes of collecting things, so almost to the hoarding level. And it can become kind of a management problem. In my kind of personal experience of working with young people, that seems to be more present with young people who have autism rather than kind of general in Prader-Willi syndrome. And then there is disobedience, blame shifting, like never admitting it was their fault, especially if the food has gone missing or something has gone wrong or things got broken. I think, to be fair, you know, some of the families will find this very, very challenging. Some of the families, I have accounted this, where a family would be very kind of forward in terms of like really expecting good manners from their sons and daughters. They would find this really very, very hard when their sons and daughters would not admit to something that they've done wrong and try to blame shift on somebody else. And then we have high pain threshold, and that's really something to be aware of. I guess from the health point of view, this is really important because sometimes young people may be seeking sensory input for their behavior and then going overboard and hurting themselves unaware that this is what they're doing. And then there's specific self-injurious behavior in a form of skin picking, which is a fascinating behavior, I think. It varies, it can come and go, and I'm sure people will have different experiences with this, and it could be quite mild, you know, could be somewhere on the kind of chest or arms around nails, but it could include quite severe form of, for example, anal picking, or some young people eye picking or nose picking to the point they're causing infections and damages that actually require medical repair following this. Okay, the next slide. Okay, now also associated with Prader-Willi syndrome, there are some social skill problems. And there's a number of kind of ways how we can look at that. There's that ASD continuum that the young people can be with, but there's also, if we mix that with the intellectual disability, where somebody's ability to form relationships and interact positively are lowered. And on top of that, we add ASD, where somebody might not be very keen to interact with others, would all impact on the social skill problems. I think in terms of kind of social skills, and when it becomes kind of a real issue, I find this transition from primary to secondary school is the time that this is really becomes to the core. In primary school, say if a young person is in a mainstream education, normally what we do see is that other young children are very friendly and caring towards them, recognizing that there is a difference between them maybe and a young person who has Prader-Willi syndrome, depending on, you know, their presentation. But on a transfer to secondary school, you may still see this caring group of young people, but there's also now little groups forming, and it becomes really important to be cool, to be able to keep up with your peers, you know, text and engage in social chit chat. And somebody who may be on an autistic spectrum may find these things very, very difficult, especially if there's a degree of intellectual disability. The anxiety that we see in Prader-Willi syndrome, it seems to be quite prevalent from early age. So the parents, we work with young people, as I said, from the youngest person referred to the service was 4 years old. So from 4 to 17 is the age range. And even kind of the parents of a 4-year-old were reporting anxiety. And anxieties were normally associated with meal times, and it could be that they are hungry, they want to see the food on the table, it could be when somebody else is eating, but also it could be about going somewhere where they don't want to go. So change of this routine, kind of moving from home and going to school, or just going outside for a walk. Anxiety seems to be quite significant in lots of young people at the time of transition to secondary school. And the way, for example, we may work with them, we may work with parents in school to look at the triggers for anxiety and try to minimize them, so to preempt what leads to anxiety. But we may also offer individual work to a young person to look at their coping skills and what exactly can they do in a situation where they feel anxious. Next item is mood disturbance. Again, quite prevalent in young people that we see. Parents sometimes report that there is this mood fluctuation in their young person, and it could be daily things. So rather than we're thinking as a manic depressive type of presentation where you have several weeks of manic behavior and several weeks of depressive behavior, this is a mood disturbance that can be changing on a daily kind of basis. And we also have excessive daytime sleepiness and underactivity. And this has been mentioned earlier today in different talks. But from our point of view, when we are managing these behaviors, what we want to do is to recognize these and find helpful ways of how we manage them. So, for example, previously it involved negotiating with schools that a particular room is found where a young person actually can have a nap during a school day if that's their need. Or for a slightly older young person, negotiating a most socially acceptable ways of managing their tiredness. So maybe if they're feeling particularly sleepy in the classroom and they could not concentrate on the work that's happening, to send them on an errand that may help, or give them an errand task within the classroom that actually may activate them a little bit and kind of get them out of this sleepiness. Okay, so the next slide. Okay, so this is now Maddie's part, so I will hand over to Maddie.
Thanks, Natasha. So thinking a bit more about behaviour interventions, which we do often with parents and schools, as Natasha's already mentioned. It's important to have a consistent approach across contexts, whether that's at home and at school. And we often use PBS plans as a way of sharing consistency. So thinking specifically about oppositional behaviours, when a child displays oppositional or defiant behaviours, there are many intervention strategies that we might advise. So this includes remaining calm. So always thinking about your voice tone, keeping your voice tone very soft, calm, avoid shouting or showing anger, which can often be quite tricky. So it might be that you want to take a deep breath before speaking to your child. It's also important to think about body language too, so neutral facial expressions and gestures, soft gestures. Giving the child choices in a positive light to allow them to feel more in control. So perhaps giving them 2 choices of an activity, just to allow them to have their voice heard. Similarly, negotiating possible outcomes, again, to allow the child's voice to be heard. What would they like to happen and why, versus what would you like to happen? And perhaps come to a fair and safe agreement. It can be helpful to offer rewards if a child complies or displays good behaviour. So lots of positive praise using vocalizations and gestures to really reward the child when they've done something good. Reward them with something they enjoy, like a fun activity, or even something simple like a sticker, if that's something that they like. If a behaviour is becoming challenging, try and stay positive and try to distract the child onto something else. So divert them onto another activity that they enjoy without paying attention to the behaviour itself. So it might be that they have an iPad that they really like being on, or a favourite game, and just trying to divert their attention to something else. Repetitive questioning can be challenging to manage, particularly if the same questions are being asked daily or multiple times within a short time period. So some ways that we might advise to respond to repetitive questioning. So when a child's asking you a question, provide specific, direct answers to avoid any confusion and offer a full explanation to the question at that point. It can be helpful to ask the child to repeat the answer that you've given back to you to make sure that they've heard and understood what you've said. And at that point, you can clarify anything that you feel they haven't understood or heard correctly. If the child continues to ask the same question, it can be helpful to divert the topic of conversation to something else that's more engaging, or perhaps using humour to kind of think about something different to what the child's asking you about. Try and have a time limit on favourite discussions. So if your child has a favourite subject that they like to talk about, try and keep a time limit to avoid repetition. That can be helpful. And if questioning persists or becomes quite difficult to manage, or conversations become repetitive, try to ignore and walk away. Although that can be quite challenging, try to ignore, walk away without paying too much attention to what the child's saying. Other things to consider might be using visual timetables to communicate exactly what's happening, particularly if a child's finding that they're becoming their repetitive questioning about their routine, because then it can be helpful to divert them to the visual timetable to show them what's going on. And simple now and next communication can also be helpful. Temper tantrums are, as Natasha said, something else that we often see, and they can be difficult. It's important to recognise the signs of a temper tantrum or outburst. So helpful to recognise when the child's agitation levels are increasing or when they're becoming more aroused. And we often think about that in terms of zones of regulation. So some of you might have heard about this. So this is thinking about the green zone, amber zone and red zone, or other names are given like 1, 2 and 3. So green would be when the child is calm and relaxed. Amber is increasing arousal or agitation. And red is high emotion. And that might be when you see a temper outburst. So at each stage, you'd want to think about, how do you know that the child is calm? How do you know that the child is increasing arousal? And how do you know when the child is at high emotion? And what do they do in each of those zones? So are they playing their favourite game in the green zone? Are they then asking more questions or skin picking in the amber zone? And what does a temper outburst or high emotion look like for your child? It can be helpful to distract the child with their interest, again, they enjoy, similarly to repetitive questioning, or distract them with something unexpected. So using jokes, humour, and other simple ways to try and distract from the outburst and the high arousal. Remove the child from the situation directly if needed. So you can divert them to their bedroom or to another safe space, perhaps getting some air outside, or remove the audience around the child. So sometimes people watching can act as a negative reinforcement. So making sure that the people around can be removed can also help as well, whether that's siblings or other people in the family. As mentioned before, remaining calm, talking softly, using simple, direct words, avoiding negative words such as no, stop, you can't. So really simple words that aren't negative. Avoid arguing or reasoning with the child when they get to this point, as this can make the situation worse. During high arousal, the child is unlikely to be taking in anything that you are saying, and actually could end up in more high arousal. Do not give in to the demand or request. So if the child is upset, for example, that they couldn't have time on their favourite toy, and you'd had to stop that, do not give in as a result of a temper tantrum, as the child will remember this, and this can cause a negative maintenance cycle. And always allow the child to calm fully before placing any other demand on them or talking to them too much. Try not to use lots of words or asking them to do anything else before they're calm. Thanks, Natasha. I'll hand back to you.
Unmuted myself now. I was saying thank you, Maddie. Okay, so we're now on to overeating and the mental capacity assessment. So both of these issues were mentioned earlier. So there was a really helpful talk with Chris on dietary management earlier, where some of these things actually were mentioned, and then obviously with Anne's talk about transition to adulthood as well, kind of issues to be considered where mental capacity assessment comes along. But I think one of the main points that I wanted to make about overeating and the food management is that I have learned so much from the parents of children with Prader-Willi syndrome. I find most of them incredibly inspirational, really good at knowledge about dietary intake, how to manage, how to combine it, what to do about it. And that's really reassuring. They often are the ones who are teaching professionals about what needs to be done with the food for their son and daughter. And that's really fantastic. One of the issues that come along is, and I don't see this really done by the parents at home, although sometimes under pressure from their sons and daughters. And when I say pressure, I mean here really quite increasing aggressive behavior in order to get what they want. And this could be food. Food is sometimes used as a reward. And we sometimes come across this in the school and other types of environments. So it could be community, it could be respite. And this is an issue that's really important to recognize and to work with everybody to understand that food must never be used as a reward or as a punishment for a young person with a Prader-Willi syndrome. So for example, and I think Chris also mentioned this, kind of saying to a young person that because of their challenging behavior, something they will not get their meal time, it's really like pouring oil on the fire, rather than actually thinking about it in a different way, that by knowing exactly when the meal times are and that they are secure, that this is going to lower the anxiety. So, for example, when we are thinking together with schools about how to manage situation around food, we will want them to consider how they will manage situation when there are birthday parties, when there are school trips, school discos, what is going to happen with access to food. And, you know, is the young person going to be restricted to food? Are they going to have their own money? How they're going to be buying everything? And we want them to be considered together with other children, so not to stand out. And obviously, you know, if a young person with Prader-Willi is going to a mainstream school where actually there are going to be things like this, like a disco night with a tuck-in shop, how are they going to manage to support a young person with Prader-Willi? And I think it's surprising. Chris was mentioning earlier, and I definitely agree this kind of the good school will be able to consider, will be open to considering and having open discussion with parents about how to manage the food in a school situation, how to safeguard this child from additional food and all the opportunities that they will get as they grow up to get these additional calories. And I think kind of building this really good relationship with the school is really, really essential to get them to understand. Our service helps families who are referred to us with this. I know Prader-Willi Association also helps families, it does psychoeducations with the schools. I think it's a really, really important part of kind of management young people with Prader-Willi. Restricting access to food. We spoke earlier today about food security. And there's a very helpful questionnaire Chris has shared on the screen with people who attended his session. And this is a document that we complete with our families. And this is really not really to kind of tell people you're doing a really terrible or really good job. It's nothing like that. It's to really consider what areas are there and have they given a thought, you know, could it be done differently, and whether that would impact positively on the behaviors that we see. So the issue in relation to food comes at 16 years of age. And this is really, if the young person is over 16 years of age, mental capacity assessment needs to be completed to assess their capacity to manage their diet independently. I think this is more issue where there is a young person that doesn't have intellectual disability, because by the nature of somebody having a degree of intellectual disability, they may not have capacity for many things, including management of their own diet. But for the ones who are more cognitively able, this becomes a big, big issue. And it's important issue for transition to adult services, because unfortunately we have seen some examples where young people kind of go to adult services from childhood services where, you know, parents had a really good control over their diet, the schools had a really good control over their diet, and they suddenly become independent. They don't want to live at home. They end up living, say, in a supported living, and part of this is they allow them to kind of do their own meals, do their own shopping without actually realizing the full extent. So this is where this psychoeducation and discussion with social workers, educational places, parents, young person, it's paramount. And of course, if the young person does not have capacity to manage their diet independently, the best interest decision that needs to be considered. And the best interest decision is usually done by the clinicians involved in the young person's care. So it could be either psychiatrists or psychologists who were doing mental capacity assessment, as well as the family, as well as kind of dietitians or, you know, teachers, everyone who has been involved in their care so far. So the next slide. Okay, so safeguarding, and I'm really, really sorry Dr. Bernard's not here at this point, because she is the safeguarding, a lead for safeguarding in our trust. So she could speak to you about safeguarding kind of a view on things for in great depth and with lots of knowledge and experience in relation to this. I think for us, when considering safeguarding in relation to Prader-Willi syndrome, comes in the form of, you know, the food management within the school environment. So that's a big issue. And so one of the things but also food management at home, it could be the situation where parents, through no fault of their own, are not able to manage their children's dietary intake. And it could be, as I mentioned earlier, that there is such degree of challenging behaviors. So it could be temper tantrums, but it could be actually quite significant physical aggression towards the parents. And we have actually seen in our clinic, you know, a situation where the police had to intervene. So I'm not kind of undermining kind of the pressure on the parents that can be, but these are the situations where safeguarding concerns need to be considered. You know, what's happening, you know, is the young person safe? Are the people around them safe? As well, is their food managed as well? But also safeguarding kind of considering when we place somebody, say in a mainstream school or say in a specialist residential school, is this educational setting looking properly after these young person needs? You know, are they managing their diet appropriately? Are they managing their physical health properly? Are they supporting them in the right way? So the next slide, please. And the role of medication can be considered as part of the treatment that we offer in our clinic. But I must emphasize here, it's always as adjunct to behavior intervention to treat specific disorders. It's never given on its own, and we would never advise parents to go and get medication for somebody to try and manage the behavior problem without actually having the behavior intervention in addition to the medication, because we know that the medication itself does not stop or change the behavior. It's the behavior strategies that do it. But what medication does is make the person more receptive to the behavior input that's being offered. Now, in terms of medication, as I mentioned earlier, I think when we prescribe medication on our service, it's usually fluoxetine or sertraline, and they are for management of anxiety. However, we have seen some young people with psychosis where then antipsychotic medications have been prescribed by local services in order to manage their psychosis. So it's possible to use them as well. We don't tend to use antipsychotic medication for young people with Prader-Willi in our clinic. And transition to adult services now ended extremely helpful talk on transition to adult services, what needs to be considered. But so one point that I wanted to make here is that when we have somebody referred to our service and we provide assessment and intervention for the young person and their family, if they are nearing to the age of transition, we will definitely start the transitioning process with the social services and adult services who will take them over, and we will provide psychoeducation to them, including social workers, new educational settings, anyone who will be taking over their care, just to ensure the continuity and this understanding of the issues that are inherent to the management of somebody with Prader-Willi syndrome. Obviously, our clinic stops working with young people at the age of 18, and I think mentioned earlier again by Anne, there aren't specific mental health services or clinics like ours for under 18, for over 18s, where it then goes to kind of adult endocrinologists to manage young people with Prader-Willi syndrome. However, we do want to transition everything that we know about the young person and share our knowledge about them and share our knowledge about management of behavior problems in someone with Prader-Willi syndrome as a way of educating local services, increasing their ability to help with management. So it's a part of our role as a tier 4 service. The next slide, please. Okay, so this is just really a summary of what we've been talking today. The Prader-Willi syndrome is a young people with Prader-Willi syndrome have got complex presentation as a result of their behavior phenotype. A comprehensive assessment is required to produce and to offer evidence-based interventions. And also the child and family are always central to our decisions. So any intervention that we offer for them, treatment that we do, it's negotiated. The goals are set together with the parents, with the young person, if possible, to try and work something which would be helpful for the family. I think this is it. This is the last, yes, this is the last slide. We have come to the end of our presentation.
Thank you so much. I'm just turning my video on, bear with me. Thank you so much, Natasha and Maddie.